Am I online? Good morning, good afternoon, wherever you are. Welcome to the fifth module of the second day of the fifth module of the UENPS Hippocrates Initiative. Today, we have the privilege to have with us Dr. TANIS FENTON. She is a registered nutrition epidemiologist and professor at University of Calgary, Cummings School of Medicine, and she is worldwide famous because of your study in nutrition in general, in infant nutrition specifically. Probably most of all, she is the famous because she developed dedicated growth charts for preterm infants that carry their name. It's a privilege for me to pass the microphone to Dr. TANIS FENTON. Please, TANIS.
Thank you for that very kind introduction, Dr. Carnelli. I'm very pleased and honored to be part of this webinar series with the esteemed presenters, Dr. Modi and Dr. Kim. I hope my presentation will be of interest to you, and I hope that I'll be able to add some perspectives and some context to some of the points that Dr. Modi made yesterday. So preterm infants grow the fastest that humans ever grow. They can double their weight in 8 weeks. But there are several misunderstandings about growth that I hope to clarify for you today. Could you start the poll, please, Katerina? We're going to have the poll up. Oh, it's only showing question 1. Is it possible to show all 3 questions at once? So the first question is, most preterm infants are growth failing, true or false? So we just have 30 seconds to answer this. Please click on your screen to answer your perspective on this question. Okay, thank you. So 61% agree with that. So I propose to you that the question, the perspective of growth is more complex than is often assumed. And it seems from reading the literature and talking to many people who work in neonatology that the problem is assumed that the cause of poor long-term outcomes is poor growth, which is caused by inadequate nutrition. But I propose to you that the problem is actually a lot more complex than this. And Dr. Modi had made this point yesterday as well in a slightly different way. So we know that the social determinants of health are highly influential to health at any age and stage. Genetics plays an influence. Prenatal factors, how healthy was the mother during her pregnancy? Did she have any health difficulties? What was the nutrition care? NICU stress is being recognized more and more as being a problem. And then morbidities also contribute to long-term outcomes. These factors do help to determine the growth pattern of infants, but the strong causal relationship is actually direct, and poor growth can often just be a marker as opposed to the cause of the problem. So what are the recommendations? I'm sure you're all familiar with these, but I wanted to make the point that both ESPGHAN and the American Academy of Pediatrics recommend that preterm infants grow similar to fetal growth. Now, I might not have the most up-to-date one from ESPGHAN, and if I am missing the most up-to-date one, please let me know. But I just wanted to make the point that currently the recommendations are to grow similar to the fetus in terms of the rate of growth. And because this is the best idea that we have. We don't have a better growth reference for preterm infants at this point in time. So what I'm going to talk about today is, first I'll show you some growth patterns of very low birth weight preterm infants with good outcomes, and then some growth patterns associated with adverse outcomes, and then point out some concerns with the developmental origins body of research. So good outcomes. So this first slide show of growth patterns shows appropriate for gestational age infants, showing very typical growth patterns of preterm infants. So the little boy on the left had some postnatal weight loss in his first few days of life, and then he proceeded to grow up to term, roughly parallel to the growth chart curves in all three parameters. He had a bit of catch up in his head circumference growth, which we often see in preterm infants, which is probably a head-sparing pattern of the baby prioritizing their head growth over their lengths and weight growth. And you can see that in the first week or so of life, there was not a lot of increase in his length or head circumference growth. People often attribute any inadequacy of growth to nutrition problems, but I propose that it's likely due to being born prematurely and having to be supported in a NICU. And it's what a lot of preterm babies do. I don't think it's a problem. So I consider this good growth. The baby on the right, the little girl, her growth was almost the same pattern as the boy on the left, except that she was a little smaller all the way through, and her weight at 36 weeks was below the 10th percentile. So she would be considered by many to have extrauterine growth restriction. In my opinion, both of these babies are growing beautifully well and showing common patterns we see with preterm infants. There are 6 studies I know of that have examined the question of whether having weight below either the 3rd or the 10th percentile around 40 or 36 weeks is associated with adverse neurodevelopment. And all of these studies found that it is not associated. So having your weight below the 10th percentile at around term age is not adversely associated with poor development. The last study is one that colleagues and I published just this year, and we approached it with a few more options. We looked at both Bailey scores and 3-year IQ scores. We looked at not just less than the 10th or 3rd percentile. We looked at weight, head circumference, and length on a continuous basis at 36 weeks, and found that there was no sensitivity or specificity to predict poor cognitive outcomes. And the year before, a group of us published a paper where we summarized 5 reasons why EUGR is not a useful categorization. First of all, it's based on arbitrary cutoffs. It ignores the normal postnatal weight loss that most babies experience, which places them lower on growth charts. It totally ignores genetic potential. It doesn't consider at all whether the child might be small genetically. It's not predictive of poor outcomes, as per the previous slide. And it doesn't consider other growth assessments. For example, how is the baby's head growing? These are 2 charts showing a comparison of infant growth patterns compared to growth charts. The one on the left is probably familiar to you. It's used very frequently in papers and presentations. It's work published by Richard Ehrenkrantz in 1999. These babies were born in 1994 to 1996, and you can see that their growth pattern is that they were falling away from the growth chart curves. On the right is some data that we published in 2013, which of babies that were born in 2001 to 2010. And these were American and Canadian babies. This graph is showing one of 3 graphs that we published showing the babies that were 550 grams on average at birth. Our cohort was of younger gestational age than Richard's cohort. And you can see in the follow-up growth that our babies regained their birth weight faster and had a faster growth, so that at 36 weeks, they were growing kind of almost parallel to the growth chart curves, whereas Richard's babies were falling off. So I'm showing this comparison to make the point that there are changes in growth over time, over the decades of preterm infants. This graph is showing a small for gestational age infant with good outcomes. So he was small at birth, he lost some weight, and then he grew roughly parallel to the growth chart curves for all 3 growth parameters. So in my perspective, he's done very well. Often it's recommended that infants regain their birth percentile at some point. And my perspective is that regaining the birth percentile before 40 weeks is an extremely rare event. It does occur, and I've got 2 examples here of 2 little girls that did regain their birth percentile, but it's very rare. And actually the birth weight percentile might be totally irrelevant depending on what happened in utero. And a baby can be growth restricted, as we all know. They can also have some excess weight if there was poorly controlled diabetes. So the birth weight percentile is a point in time that may not be relevant anymore after birth. So on the left here, we have an SGA baby who caught up in her birth weight percentile by 37 weeks. And in our cohort study, we found that regaining the birth weight percentile among SGA infants is less rare than it is among AGA infants. 14% of our SGA babies regained birth weight percentile. The baby on the right was appropriate for gestational age. She regained her birth weight percentile, which we found occurred only among 8% of AGA babies. And I speculate that those AGA babies were actually growth restricted. We tend to think of being below the 10th percentile as growth restricted, but a baby can be growth restricted and be born on the 60th percentile, as this baby was, because perhaps her genetic potential was that she should have been born on the 97th. Large for gestational age babies aren't often reported in terms of their growth patterns. And here too, on the left, we have a baby, a little boy who was large for gestational age for all 3 parameters. He had his weight, his length, and his head circumference were all up above the 90th percentile. So when I see a pattern like this, I say, okay, this child probably is large genetically, and he probably should stay large, which he did. And, you know, we don't see a lot of babies with weights above the 50th percentile at 40 weeks, but he achieved it, which isn't surprising. He actually was growing parallel to the growth curves up to, you know, from about 31 to 36 weeks. And then he was actually showing a bit of catch up even. So I find this growth pattern is appropriate. The boy on the right, his weight was above the 90th, but his head circumference and length were not. His mother had maternal diabetes and poorly controlled. And so my assessment of this little boy is that he probably had some excess weight in terms of excess glycogen and fat at birth. And over time, you could describe his growth pattern as failing because he's not keeping up to a parallel growth to the growth curves for weight. But I think that he had some excess weight and he was not maintaining that excess weight. And so I would rate his growth pattern as appropriate given his history. So I've shown you patterns that I thought were good growth patterns. What do poor growth patterns look like? So this is actually a composite. It's not an individual baby. It's a composite from our cohort study of babies who had low IQ scores at age 3. There were about 30 of these babies, and there's a bit of noise because when you use composite data, sometimes it's different individuals that are plotted. These are the median curves. And to really put this growth pattern into perspective, it's good to compare to the babies who had good IQ scores at age 3. And you can see there is some noise all the way through, but I think we're seeing a separation and poor growth after term in the babies that had a low IQ score. Now, I don't have their feeding data after term in our database, but I speculate that the reason that this baby was falling off after term, after discharge, might be that babies who've had a severe interventricular hemorrhage have some feeding difficulties after term, which causes them to growth fail. So often we think of the causal pathway as poor growth causes poor in cognitive outcomes, but I think that it's actually reverse causation, that the causal pathway starts from the brain injury and then goes to feeding difficulties, and then feeding poor growth is the outcome in this situation. So what size is associated with poor cognitive development? And there's consistency in the literature. And I was just chatting with Dr. Carnelli, who has some work just about ready to publish showing this same finding. And that is that when we see small sizes associated with poor cognitive outcomes is after term age. The studies have documented this between 3 and 24 months corrected age. So we don't see the association before discharge, and that probably is because, again, it's speculation, that in units that are supporting babies nutritionally and have good nutrition care and also use tube feedings, we can grow them really well in the NICU, and after discharge they're needing to nipple feed themselves. Those studies are all summarized in the reference I have at the bottom of the page. So my assessment of the babies with the low IQ scores who are falling off the growth chart after term age is that this is poor growth after discharge and it needs investigation. What kind of support do these families need? As Dr. Modi mentioned yesterday, infants with morbidities have different growth patterns than infants without morbidities. And these are our weekly cohorts of our babies in our cohort study. And you can see that the babies with morbidities had lower patterns of growth for weight length and head circumference. And they were showing some catch up onto the, from below and on the 3rd percentile, they were showing some improvements after term age, but compared to the infants without morbidities, they were not doing as well. And I agree with Dr. Modi that the solution to all of this isn't necessarily better nutrition. We need to ensure that nutrition is adequate, but we can't remove all adverse situations by providing nutrition, as much as nutrition is important. So what are the risk factors for a poor cognitive impairment in these babies? It wasn't growth, So what we found was predictive of poor cognitive impairment were brain injuries and also low maternal education. In other words, the social determinants of health as well as brain injuries. So what do you think of this baby's post-discharge growth? So his parents aren't tall. His mother had uncontrolled diabetes during pregnancy. It's actually the same pattern I was showing you before, but I'm showing you some of his post-discharge data. And you can see that his length was improved from when he was in the NICU. There's a bit of improvement there. His weight has come up quite a bit. Now, he was not the one that was large in all three parameters. Rather, his weight seemed to be a little higher than his length and head circumference. So he seemed to have some influence from her diabetes. But I'm concerned about these data points here after term age. And this looks like excessive weight gain. It could be that the parents are actually force feeding him and not paying attention to his cues and feeling that he needs to be growing faster. And it's always nice if there's follow-up for parents so that growth can be assessed to help them make the right decisions and provide the most supportive feeding environment for their child. And as Mandy Belford has pointed out a couple times, increasing weight out of proportion for length does not confer developmental benefits. So a related question, another concern I see across neonatology is the concern about the often reported higher body fat percentage in preterm infants compared to term infants at 40 weeks of age. And another point that is worth pointing out is the American Academy of Pediatrics actually recommends that preterm infants have the same composition of weight gain as the normal fetus. But I actually think this is not good advice because I think it's fairly well established that preterm infants have higher body fat percentage at 40 weeks. What you can see on this graph with the preterm infants on the left and the term infants on the right is the growth curves that were developed based on a review of the literature of the body composition studies that have been published. The size of the dots reflect the sample size of the studies. And what you see when you look at 40 weeks is that the average preterm body fat percentage was 16%, whereas for the term infants, the average percent body fat was 10%. But when you get up to 3 months of age, 52 weeks, both sets of babies, and no matter what the birth, there was gains of fat in the early months. We see that in term infants all the time, and it's seen in preterm. By the time you get to 3 months, the average body fat percentage of the preterm infants was 24, whereas the term infants body fat percentage was just over 25%. So I propose to you that preterm infants gain this body fat postnatally. It seems to be a temporary event. The timing is different. They gain their body fat earlier postnatally. And so I propose to you that there is no need to be concerned about this higher percent body fat because it is a temporary event. So what about adiposity at older ages? Another concern throughout the literature is, and Dr. Modi presented the concern as well, that preterm infants might be overweight as adults. These 4 graphs are our cohort studies information on how the weight up in the left, the weight, the length to height, and head circumference and body mass index changed from birth up to 3 years or 36 months of age, we stratified our babies by the ones that were in the overweight category at 3 years versus those that were not. And let's zero in on the weight chart. So there, you can see that the infants that had grown to become overweight at 3 years had quite a steep weight gain to get there. That would be required to get overweight. They did need to gain. In contrast, those babies that were not in the overweight category, using the WHO definition of greater than 2 standard deviations at age 3, their average weight was less than the median of the WHO curves. These curves are my curves in the early weeks up to the WHO up at 3 years. Of interest, there was no important or significant difference in weight for these two categories until 4 months adjusted age. And you might be interested to see the distribution of the body mass indices of of all of our cohort at age 3 years compared to the WHO growth standard. So these bars and the lighter curve are our babies at 3 years. The darker dashed curve is the WHO growth standard. And what you can see is that the preterm infants tended to be on, the whole distribution was shifted to the left. They tended to be lighter. Oh, there's a typo there, sorry. They were lighter than the WHO growth standard. But you could ask the question, well, 3 years is kind of young. What about older? And actually, this isn't a systematic review, but I have been collecting references that evaluated body mass index or body composition in preterm infants at older. I've ordered these references in terms of the age at which these assessments were made. And in all cases, the preterm infants were had either lower or similar body mass index, and some of the studies indicated that they had less lean mass. And we asked our cohort study, what are the predictive factors for childhood overweight? And interestingly enough, the first two are the same as the outcomes for poor cognitive development, that is brain injury and low maternal education, and an additional one, which was maternal diabetes. Dr. Modi was mentioning growth monitoring using grams per day, and I wanted to just show a graph from work we did summarizing various growth references for preterm infants to show the up and above the grams per kilo per day, either using the average method on the left or the exponential method on the right, and you can see good agreement. You can see that the often quoted 15 grams per kilo per day is low up until about 35 weeks, and then it's too high. But that's often about when infants are discharged. So I do endorse the use of grams per kilo per day for preterm infants. For grams per day, you can see that the growth references show a dramatic change between 23 and 35 weeks because, and if you think about it, a 10-gram gain for a 500-gram infant is 20 grams per kilo per day, but a 10-gram gain for a 1,500-gram infant would be 7 grams a day. So I find that grams per day is not very useful because what we expect of the babies changes so dramatically for the time that they are in an NICU. Another problem I have found when people focus a lot on growth velocity calculations is that they give a precise value and don't give the whole perspective of how an infant is growing. For example, this little boy had maybe a bit of fluid retention at one point, and when we calculate his his growth velocity, it was not consistent. He had the week of the 32 week, he only gained 8 grams per kilo per day. Looking at his growth pattern, I would say he's doing quite well. I'm not really concerned about his growth, but if you calculated that his growth was 8 grams per kilo per day, it would mean you'd have to make a big change in his nutrition. But his weight gain in grams per kilo per day was 24 grams with that fluid retention. So we get too much precision using growth velocity calculation. So I encourage people to look at the patterns of all 3 weight, head circumference, and length. And so another causal diagram for later overweight is it's assumed that all overweight is, first of all, very likely in preterm infants when you read the literature, and it's assumed that it's because of the nutrition that has been provided, and poor growth is considered to be a risk factor for later overweight, particularly in the developmental origins hypothesis. But I argue that the problem is more likely that what leads to overweight is the social determinants of health. That's well established as a cause for overweight in all populations. Prenatal factors can have an influence, and then the food environment that the child is discharged into is important as well. Dr. Modi yesterday, this is a copy of one of her slides. She expressed real concern about chronic diseases and reduced lifespan in preterm infants, but this is actually one of my prime areas of research. And when we read the neonatal literature, we find that people are saying we need to make a trade-off between supporting growth for cognitive outcomes, but we might be causing long-term cardiovascular, overweight, and metabolic problems. So do we need to make a trade-off? So this area of research is often referred to as the developmental origins of health and disease, also the Barker hypothesis. But it's actually really interesting when we look really closely, we see that there is a real concern with the regression analysis methods that are used in this area of study. And specifically what the concern is that these studies usually adjust to remove the effect of later weight. But later weight is a very strong risk factor for high blood pressure, metabolic syndrome, and adiposity. The studies that have examined this situation have found that the adjusting for later weight makes the analysis unstable, unpredictable, and it also alters the precision. And the causal model that's often referred to is that being small for gestational age causes higher body weight and then causes cardiovascular markers to go up, overweight, and metabolic problems. But what we need to adjust for, which is a very important cause of both SGA and also these outcomes, are socioeconomic factors. And the practice of adjusting for a mediator on a causal pathway does cause problems in regression analysis. So one of my students published this paper recently, and I'm going to review it for you very quickly. So she examined the associations between being small for gestational age and overweight and found that there was no important association with wide confidence intervals. When she adjusted for weight, then the results suggested significant positive, strong association with an odds ratio of 6.6. That's dramatically high. And then she used marginal structural models to examine the direct effect of small for gestational age on overweight, and the odds ratio came down to the ballpark of above and actually suggested perhaps even a protective effect. Sorry, I click that too quickly. And so what we concluded was the crude and adjusted for confounders models yielded null associations between SGA and overweight, but adjusting for body measures can change the association between SGA and overweight, providing spurious estimates. Others have observed this problem, and I suggest you have a look at this paper by Williams et al. Published in Pediatric Research in 2018. They have a good section on the problem of adjusting for later weight. So we have some systematic reviews underway now to examine the body of evidence for SGA infant risks, preterm SGA infant risk for high blood pressure and overweight compared to preterm infants who are not SGA. And then to examine what has, which papers have adjusted for later body weight and what is the influence. And here's some of our blood pressure data from our systematic review. We considered that a priori, we considered that if the study should adjust for the social determinants of health. And so in this, we did find 2 studies that had done an adjustment for the social determinants. They were Maureen Hack and Mandy Belfort's work. And they estimated that the blood pressure at later ages for SGA infants were actually lower than, it was not significantly lower, but lower, not higher for SGA infants. This next forest plot is showing all the studies that had residual confounding because they didn't adjust for the social determinants. And in this case, the finding was a null finding, no difference in the blood pressure of those born SGA versus non-SGA. We found 18 studies that fit in this category. 3 of the studies had reported results that were and were not adjusted for later weight. And when there was no adjustment for later weight, the estimated blood pressure of SGA infants was lower by 1.5 millimeters of mercury. And when the weight adjustment was added, the significance of the above association disappeared. So we had an altered precision with the adjustment of weight. I had the privilege of being able to contribute to the latest Koletsko book, Nutritional Care of Preterm Infants. And part of putting this book together were some all authors meetings, which would have been in person, but because of the pandemic had to be virtual. So we voted on some growth goals for preterm infants, and these are the ones that were agreed upon through that process. And that's number 1, support preterm infants to grow at rates and accrete nutrients similar to the fetus. And actually, I would add now, after hearing Dr. Modi's presentation, to add and have functional outcomes similar to a term-born child. Number 2, aim for preterm infant growth to maintain weight, head circumference, and length growth patterns. That is to aim for growth that's approximately parallel to the growth chart curves. Quoting Mandy Belfort, increasing weight out of proportion to length does not confer developmental benefits. Number 4, gaining additional body fat postnatally appears to be a temporary event. Number 5, an infant's growth pattern deviates importantly from, if an infant's growth pattern deviates importantly from expected growth patterns, ensure nutrition is optimized and assess for possible contributing factors. Number 6, preterm infants place lower on growth chart curves after the postnatal weight loss phase. The phrase extrauterine growth restriction should be retired and not used to diagnose infants with weight below the 10th or 3rd percentile, since it is not predictive of adverse outcomes. So I've been recognizing that the needs to quantify growth and assess growth are different for clinical care and for research. So for clinical care, I suggest that because every individual has individual situations that they need to be assessed individually rather than using cutoff points and to assess, for example, EUGR. Rather, we need to have everyone look at the growth patterns. How is this baby doing? For research, there is a need to quantify growth. And what I and colleagues have come to recognize and recommend is that, first of all, if we're going to talk about growth, we should take out the postnatal weight loss phase, because that's not a growth phase, and then begin the growth quantification at the nadir or day 7. The nadir, it's really challenging in a large study to identify the nadir for each baby and then have their individual growth calculation. But it's much simpler to use day 7, and that's most, we found it most associated with the growth rate from the nadir, so it's a shortcut. And then it's good to quantify growth velocity using either the average or exponential method. Using the early method really exaggerates the numerical value. Or changes in Z-scores, Z-scores are useful for research quantifying. And a change from Z-scores from birth can be relevant to report, but it's not equal to growth, but because it includes that postnatal weight loss phase. So let's, oh, I don't have the question. I'm giving you the answer. Here's the answer to question number 1. Question number 1, most preterm infants are growth failing. The answer is false, because many grow parallel to the growth chart curves, which is success. I had asked for the second poll question that didn't show up, but that's okay. Preterm infants should return to their birth percentile for weight by the time of discharge. False, it's not relevant after their postnatal weight loss phase, and given the difference between their intrauterine, genetic, and postnatal influences. And question number 3 was the best clinical growth assessment is based on, and I recommend that growth charts be used to observe the patterns of weight, head circumference, and length. And I think growth charts based on birth size, such as my growth chart, give you context to know if a baby is gaining or losing excessive amounts. I want to invite you all to the Society for Neonatal Nutrition, Gut and Growth. A colleague and I, Dr. Bilal Al-Sheikh, have set this up at the University of Calgary. The address is in the red font on the upper right. And we invite you to join as members. We hope to be able to distribute information about webinars like this through there. What we have done so far is to add evidence-based guidelines, nutrition and growth guidelines, including data from the Pre-B project. The Pre-B project was initiated in the United States to develop dietary guidelines for preterm infants, and we took a systematic review approach. We have now published, I was involved even though I'm a Canadian. It was a pleasure to be involved. We have published our guidance of our summary recommendations, as well as our paper on the evidence about enteral protein, and our paper on breast milk is under review at a journal. I wish to thank my many collaborators that have helped me accomplish the work that I've presented to you today. And my take-home messages are that aim to meet nutritional needs for all infants, aim for growth that is parallel to growth chart curves, and always remember biological variation. It's very normal to see a range of sizes and growth rates. This graph is showing the actual individual patterns of weight gain of our cohort, our 23 to 25 week cohort. And you can see, even though they were 23 to 25 weeks, they had a very wide distribution, almost up to the 97th percentile. by 50 weeks. I thank you very much for your time and attention. And if you want to use graphs similar to the ones I showed you today, there's a web-based app that's free to use, which is shown on my webpage that you could use to plot the baby's growth in your care. Thank you very much for your time and attention.
Thank you very much for this wonderful lectures. I pass the microphone to Joe, who will be leading the discussion. Please, Joe.
Thank you. This excellent lecture. I really, again, just as with yesterday's lecture, a lot to think about, and some dogmatic concepts that we have been taught all along that we need to give a little bit more attention to than we have in the past. So thank you very much. There are a few questions here. The first question is from Vilma Ivanosakini. I'm sorry if I pronounced that name incorrectly, but I would like to ask Professor Tannis-Fenton about babies who had poor growth after discharge. Do you think we should check them? IGF? IGF is low, should we treat? Did you hear that?
No, sorry, you froze there, Joe. Sorry about that.
Yes, I'm sorry. I have a little difficulty here. So the question is, babies who had poor growth at discharge, do you think we should check them for low IGF? And if IGF is low, should we treat?
I have to say I don't know. I encourage that we look broadly. I don't know if IGF is a helpful marker. If it's after discharge, I would first focus on how are the parents coping, and how is the baby feeding, and even have perhaps even a feeding assessment by an occupational therapist. I don't know, does anyone else have an answer? Jay, do you have an answer about usefulness of IGF?
I don't think I can add much to it. I know that people have measured across the preterm versus term populations, and clearly IGF is deficient, particularly early on, but no data with respect to supplementation later.
Yeah, and whether, it may be low and growth is low, so it might just be telling you what you already know. And yeah, we need obviously some research, and maybe there is some that I'm not aware of.
If I may add, yes, I think it's what the Tannis says is very true. It's low when growth is low, is lower in SGA baby. So it's sort of associated with growth, but whether intervention can ameliorate this, are justified, I would say we don't know at this moment.
So here's another question. What is the correct way to do this? Take the weight, height, and head circumference with the real gestational age or the corrected gestational age? This is from Manuel Bernal.
Oh, I'm not sure exactly what he means about real or corrected gestational age. Maybe he means postnatal age versus corrected age.
I think that's what he means. Yeah.
Yeah. So I think it's really helpful to evaluate growth relative to gestational age, because growth changes so dramatically. The fetus goes from a few cells to, the reference fetus to over 3 kilos in 9 months. They have extremely rapid growth that reaches a peak in terms of centimeters per week at 34 weeks. And then growth is slowing after that. And the graph I showed that showed the grams per day versus grams per kilo per day, you can see that growth changes dramatically with gestational age. So I really think it's important not to plot by postnatal age, but by gestational age.
Thank you. There's another question by Thibault Santerre. Great presentation, TANIS. Could you discuss the value of Z-score change to better assess and illustrate growth pattern in any preterm infants? In order to help clinicians, what would you consider an ideal weight Z-score change from birth to 36 to 40 weeks post-menstrual age for avoiding both excessive and insufficient weight gain?
Well, I think Z-scores, changes in Z-scores can be useful clinically. You know, it's nothing, it's a good numerical summary to say this baby's only gained 8 grams per kilo per day this week, I'm concerned. But as I pointed out with that one graph, it's one segment of time, and we need to look at what happened prior to that. And we need to know where the baby is on the growth curves. As I showed, if it's an LGA baby from a mom who had a poorly controlled diabetes, I would accept lower growth velocity than if it was a baby from any other situation. So I think the Z-scores give wonderful numerical summaries, but they can give you the wrong picture if they're not used without looking at the growth chart at exactly the same time. I hope that helps, Thibault.
Okay, thank you. And here's a question from Nick Ambleton. The lack of clear separation in the less than 30-week 1,500 gram with low normal WISC is impressive when viewed in retrospect. No specific question for you, but any further comment? That's question number, or point number 1. And number 2 is it may not be of concern that the FM, I think fetal mass is higher, fat mass, yes, is higher in preterms at 40-week corrected age, but higher fat mass percentage means lower lean mass. Should we not be concerned that lean mass in preterm is significantly lower than term infants?
Mm-hmm. Mm-hmm. Yeah, Nick, I agree that we do need to be concerned when lean mass is lower. And I think what we really need is research that evaluates how changeable it is. Is it modifiable? You know, is it, you know, if lean mass is reduced because of the preterm birth, NICU stay, stress, et cetera, then, you know, we need to find out how modifiable it is, but it definitely is a concern. And I agree. And I'm not sure what you mean by WISC.
Go ahead, Virginia, please.
Well, I think it's neurodevelopmental.
Oh,
Yeah,
the
scale.
IQ. Oh, the IQ. Yes. Yeah. No specific. Well, I think.
Did I get it right, Nick? Am I right?
I think he means WIPC. I think he does. Yeah. So I would take you back to that first causal diagram that I showed, where you know, there are other factors other than growth that are determinants of IQ scores. And in our cohort study, and other studies have shown the same, one of the strongest predictors are severe interventricular hemorrhages. And, you know, unfortunately, nutrition can't reverse that problem. It reflects the challenge that we deal with working with these babies is they present challenges to us. And, you know, we need to do our best to give them the best support possible, but we can't overcome every adverse circumstance.
Here's another question from Thibault Santeri. What would be your advice for assessing the ideal Z-score and anticipate the genetic potential of preterm infants in order to help the clinician to define a growth goal target for an individual preterm infant?
Oh, it sounds like you want a specific mathematical approach. Again, I prefer to look at the growth pattern of the growth charts and consider the size of the parents. And then, you can have parents who've come from an adverse situation, perhaps even a refugee situation, where they might be growth restricted themselves. So looking at the parents isn't a perfect assessment of the genetic potential, but it can give some clues. And so I think, up to 36 weeks, it's fine to aim for 15 to 20 grams per kilo per day. But I think we need to look at the whole pattern and consider the nutrition. And, human milk is highly variable in protein. So there are just so many things to think about, to consider how we support these babies.
If I may, we have looked in our cohort. We have the height, the anthropometry of the father and the mothers, and their preterm babies. And this is nearly 1,000 babies, so it's in 1,000 births or so. It's quite a number, and there is no correlation between fetal size, or very small correlation with fetal size up to 40 weeks. At 3 months, you start seeing effect. At 12 months is apparent, very clear, and at 2 years is astonishing for length and everything. So it seems that the correction for the parents start to become important 3 months or so. I'm happy to share this data at some point.
Oh, that sounds fascinating.
There was a lot of work, and we expected that some kind of linear thing. I mean, that it would be apparent throughout, but that apparently was not the case.
Oh, that's fascinating, and it actually fits with my understanding, because the intrauterine environment influences the size of the baby, and then the genetics take over, particularly once the child can self-feed and determine the amounts. That's interesting.
Not so apparent in the less than 32, in preemies less than 32 weeks. That probably, it's also can be that you have a confounder that in their populations, right? Which is not really, they go beyond the parental size. We see, for instance, the firstborn as compared to secondborn, 120 gram difference, matched for everything. So these biological effects are there, but the correlation, it's in a sizable number of babies. We could not find for that particular gestational age segments, the younger ones, less than 32.
Can I ask a question to you, Virgilio, about
Yes.
that? Did you, in your cohort, did you have a lot of parents, particularly mothers, that were themselves severely growth restricted? Because I think that it could be also that you didn't have enough in that specific category to look at a signal.
Yeah. Well, I don't know how to answer properly. We have 20% of the baby are SGA, 18%, as it is typical of this cohort, because there you are overestimate of SGA at the lower because of iatrogenic birth and so on. The SGA mothers, let's say for adult standard, were 10%, not an overrepresentation, and SGA mothers had lower education than AGA mother, and it was statistically significant. So that's also a kind of newish. You can expect this. So the shorter mother and thinner mother, for some reason, had a statistically lower education level compared to the larger mother, let's say, which is not unexpected. But we have not looked really at the correlation with the fetus. We'll look further into it. Thank you for your question and suggestion, perhaps.
Yeah, it's unfortunate that we are running out of time. There are several other very good questions here, but I think we're going to have to stop here. And I really appreciate, and we all appreciate your excellent lecture, TANIS. This has been a great set of sessions so far. Look forward to Jay's lecture tomorrow. So thank you, everybody.
Yeah, if people have questions, you can email me.
Okay, great.
Thank you, everyone. Take care.
Thank
Thank
you.
you all. Bye.
See you tomorrow.
Bye.
See you tomorrow.
See you tomorrow.